Welcome to another Orthobiologics Tonight with our host, Dr. Seth Sherman, Dr. Ken Zasloff, and tonight, our special guest, Dr. Joanne Borgstein, Dr. Andreas Gomol, Dr. Adam Yanke, Dr. Dan Saris, and Dr. Jack Farr. Welcome!
And live from our home to yours, it's Orthobiologics Tonight. I'm Seth Sherman from Stanford University, joined as always on Thirsty Thursday by my loyal sidekick, Bullet Bourbon. I need it after the OR day today. Unfortunately, my two other loyal sidekicks, Rachel Frank and Jorge Chala, deserted me this evening, but luckily we have Ken Zasloff joining as our special guest host. Hey, Ken, thanks for being here.
Great
all
to have you.
As the past president of ICRS, he's a leader in our Biologics Association and currently in clinical practice at Northwell in New York City. We have an incredible lineup for you this evening, and I'm really excited to be here tackling controversial topics in focal cartilage defects. So we'll introduce our future speakers in a moment, but here's the agenda. We're going to have a good overview talk. We're going to have a intriguing debate, rapid fire discussion, and question and answers from you, the audience. So without further ado, I turn it over to my buddy, Ken Zasloff. Take it away, Ken, and introduce our first speaker.
Thank you, Seth. Very excited to be here tonight with this great crew. You should know we're quite the itinerant group. Only one of us here, Jack, and maybe Joanne as well, has been in one place for a long time. The rest of us keep moving city to city, but we're happy to be in our newest homes. In any case, we're going to start off with a quick discussion of our products tonight and what we're going to be looking at by Andreas Gomol, also a partner here at Hospital Special Surgery in New York City, and has been a longtime member of ICRS as well as the Biologics Association. Andreas, take it away, please.
Hey everyone, good night from New York. Let me just share my screen and cross my fingers that this works. All right, I have a few conflicts, which you can see here. You can also find those on the Academy website. I've been asked to give the rationale for biologics, and this is really trying to frame the question of why are we even talking about biologics. So what is the role of biologics? And I'll limit this to chondrosis or cartilage disease, so not any soft tissue injuries. So ideally, we'd like to prevent cartilage damage if we could. Modifying disease progression would be great. What we're doing currently is the non-surgical treatment of OA. And then we as surgeons are especially interested in using biologics as the surgical intervention if it comes to that. So what about prevention? If you have a history of a knee injury, knee OA is more than 7 times more likely than in those patients who didn't have an injection. And for us, we see ACLs all the time, especially if you have a meniscus tear that can't be repaired. But 50% of those patients can be expected to become symptomatic with OA after 10 or 20 years. And with increasing numbers of ACL, about 250,000 being done every year, 10 to 20 years sounds like a long time for a young patient, but the average age for an ACL is in their late teens, early 20s. So even 20 years puts them in their late 30s, early 40s. And from my own perspective, that came and went pretty quickly. So if we can do anything to mitigate damage associated with that acute injury, ACL tear, patella dislocation, intra-articular fracture, if there's anything we can do, well, some damage has been done, but other damage similar to ischemic stroke develops after the fact. And if we can do anything to preempt that, steroid injections, one of our friends, Christian Lademan, has done research looking into the effects of aspirating the hemarthrosis and giving a cortisone injection. And it showed that decreases cartilage catabolism very quickly. And now he's moved on to looking into IL-1 receptor antagonists to see if that does the same or better. So there's a lot of work going on in the prevention of cartilage damage post-trauma. Modifying disease progression would probably save all of us a big bundle, because the direct and indirect costs even 20 years ago was over 65 billion a year in the US. So if there's anything we could do to keep these things from getting worse and worse over time, so if we could somehow come up with disease modifying agents similar to what our rheumatologists have, would sure be nice. But a lot of companies have shown interest, but most of those studies have failed in phase 3. And that's not for lack of trying. It's just really difficult to define endpoints, at least structural endpoints for OA, because X-rays, they might be cheap, but they're not really sensitive. And OA is multifactorial. It's a really slow disease. No one really has the patience to do a study that looks at one intervention and then checks in 10 or 20 years later. But there are some currently under investigation, whether that's bisphosphonates, vitamin D, glucosamine, Wnt pathway inhibitors. So also a lot of work going on in the area of modifying disease progression. That sort of would be the holy grail, not just changing symptoms, but slowing down further progression of disease. The non-surgical treatment of OA, and I won't go really deep into this because Joanne, I think, will be talking about this a little bit. But I think we all realize that we need something for these tweener patients that are too far gone for biologics, but are too young for arthroplasty, where we don't really have a good solution, as much as that hurts saying that as a surgeon. But if you look at this, for example, that's a pretty catastrophic knee with multiple loose bodies. Joint space is sort of there, but definitely doesn't look good. And if I told you that this patient is 75, I think everyone would probably say, let's go ahead and do a total knee. But this kid is 26, and the only injury he ever had was a single patella dislocation on the right. And something biological was set off that brought him from a knee that looked like his left knee still does to what it looks like now. He had a bunch of clean out scopes. He has severely limited motion. There really isn't a great surgical option. But why actually is arthroplasty not a good option? Why do we even bother with all of these preservation procedures? And some of the arthroplasty surgeons here, who are my colleagues, say, why do you guys bother? They always come to me at the end anyways. And they might be right. But if you look closely in some of the larger outcome studies of arthroplasty registries, about a quarter of patients wouldn't do it again. And this is just talking about patients who are age appropriate. So 60, 70, 80. If you look in total knees under the age of 60, all of a sudden things get much worse. So survival goes down, and almost half of patients, even with surviving implants, say they have moderate to severe pain. And that's just with primaries in young patients. If you look at the outcomes of multiple revision total knee, that's really disappointing. So if you look at this graphic at the bottom, if the red ones are arthroplasty interventions and the blue ones are biologic interventions, our goal is really to just push back when we are doing the first metal and plastic. Head to head, if you look at the direct, quick, sort of early outcomes, especially after uni compared with something biologic, the uni might be better early on, but the problem is the uni always leads to a total, and then that total leads to another total. While if you could get something in before and you push off that first uni till the third intervention, then maybe they can get away with just one total and they're done. So there is benefit to that. So what is joint preservation? Well, trying to improve pain and function without arthroplasty. And as a surgeon, we generally imply surgery, but it does include non-op. And I also do a lot of that, like I'm sure all of us do. And broadly speaking, actually, even meniscus repair, ACL reconstruction, all of these are joint preserving options. Anything that tries to delay progression of disease until a more appropriate age. So specifically biologic joint reconstruction, what's important about that is that you shouldn't just focus and zero in on cartilage disease. That's just a focal issue, but by and large, the whole joint is involved to some degree, which means we don't only look at the cartilage, we also look at malalignment, ligamentous instability, and meniscal deficiency. And those other operations are just as important, or sometimes even more important than cartilage repair. But just to give you a little overview of why it's important to delay things, even though looking at this, for this girl, I had to fight with insurance that said at age 17 she should have a total knee and not anything biologic because quote unquote osteochondral allografts were not indicated for osteonecrosis, which is what she had. So she had a successful bone marrow transplant, and unfortunately her knee wasn't quite as successful. So you can see the lateral condyle is all delaminated, and this was treated with an osteochondral allograft plug. This is her 7 years post-op. Arthroscopy images look good. She had maintained joint space and the allograft looked good. So this is something where we were able to give her quality of life at an early age without arthroplasty intervention. This is a kid, he's 29, he had lateral pain, he had multiple meniscectomies, meniscus repairs, even had a meniscus transplant that failed, and his cartilage is coming off in big flaps. So he ended up with a bipolar osteochondral allograft laterally with a tibial hemiplateau and an osteochondral allograft for the femur. And this is him with a repeat arthroscopy because he did get stiff, but all of a sudden it looks like a joint should look in a 26-year-old. So joint preservation, cartilage disease in the young is a really complex problem. And that's only beaten by the even more complex decision-making because there's no defined criteria who really is a candidate for surgery like this. It's all based on small cohort studies, sort of expert opinion. For me, oftentimes in these patients, the indication is almost by exclusion of alternatives. They're too young, they might be too active for a total knee, they're too symptomatic for just ignoring it, and generally conservative management has not been effective. You really need to look at each case specifically. And like I said, these concurrent procedures, meniscus alignment, ligaments, are almost always required. And the one thing we need to be careful, because these are young patients, they don't deserve to be in the trouble they're in. They want to be just like all their friends are. But even though we can try and preserve their joint, it doesn't give them a normal joint. And specifically, it doesn't allow them to preserve their whatever athletic ambitions they might have. So can they do some sport? Can they stay fit in the gym? Absolutely. But can they do double headers or play basketball all the time? They might be, but that shouldn't be the goal, and that shouldn't define success. But if you look at how many of those we can keep away from arthroplasty, at least within 10 years, about 70 to 80% of these patients have a survival free of arthroplasty. And 10 years, that might buy them one fewer revisions in the end. And to me, at least, that's definitely worthwhile. So with that, I want to give it back to Seth and then to my co-author. Thanks very much.
Thanks, Andreas, for setting the stage for us tonight. There are a couple of similar questions blowing up the chat, and just for a moment, I want you to answer briefly. There was a question about asymptomatic ACL and whether you're doing surgery for that to protect the knee for the future. I think there's some thoughts there. So just curious, very briefly, because we have a big agenda, and we can get back to it in a rapid fire.
Yeah, so Jack actually talked about this a lot, not necessarily for ACL, but meniscus deficiency. Are they truly asymptomatic, or have they just dialed down their activity enough to be asymptomatic? So you always need to ask them what they're actually doing. And if somebody says, "Oh, I don't have any issues, but I actually just use my bike and sit on the couch," they might be okay with that. But if you really talk to them and say, what happens if you try and do more and then they become symptomatic? It certainly makes the discussion a little bit more complex, and I don't advocate for operating on completely, truly asymptomatic patients, but sometimes people aren't even aware of how much they've dialed back their activities.
I think that's a great statement, and I think we'll hit on it later on with the whole panel, thinking about patient expectations, their current level, their later demand, effusions that are asymptomatic, are they really? So there's a lot to dive into there. Now it's time to move on to our crossfire debate. So arguing the non-surgical approach and representing all of PM&R, who's joining us tonight, is Joanne Borg-Stein from Newton Wellesley Hospital. She will try to convince a very hostile crowd that non-operative is a viable option here. We then have a trifecta of orthopedic surgeons covering the vast landscape of cell-based surgical repair. Adam Yanke from Rush will argue for standard cartilage repair strategies. Dan Saris in purple from the Mayo Clinic will show us a more radical approach. And then the one and only Jack Farr from Ortho Indy will ride the party line as the elder statesman, although he looks great, and the voice of reason. So 5 minutes each, and we're on the clock. Joanne, share your screen and take it away.
Back to Senator.
First of all, thank you very much for the invitation. I'm really happy to be here. I'm not a terribly confrontational person by nature, but I'll do my best. And when it comes to focal chondral defects, this is an area where collaboration between surgeon and non-surgeon is probably one of the most important things we can do. I have no disclosures. So the goal of non-operative treatment is pain relief, optimization of function, reduction of inflammation. But we're clear at this point with available techniques that non-op treatment does not restore cartilage and does not seem to modify disease progression as we know it. That said, the long-term results of non-operative treatment are not well studied. This study, for example, looked at a 14-year follow-up. 75% of the young adults in this study had good to excellent knee function, although 50% demonstrated increase of their abnormal findings on MRI. So is there really a correlation between MRI findings always and function? Our non-operative treatments, of course, include a careful history, physical imaging review. We generally, or I generally will use point of care ultrasound. There are frequently extra articular components to the pain that we can address and focus on. Lifestyle modifications, oral and topical meds, biomechanics, therapy injections. I will briefly touch on each of these. Patient assessment, of course, some of the things that we look at beyond sort of imaging in the knee exam is how well their patella tracts, their alignment, their gait, their core control, their balance. We even look at the foot core because certainly that can influence overall kinetic chain function. And then, of course, imaging is added. Lifestyle optimization is key. Nutrition, sleep, adequate rest, adequate BMI, greater than 25 is associated with more accelerated osteoarthritis, exercise, and of course, unfortunately, activity modification. Topical treatments like diclofenac gel, biofreeze certainly have a role, as well as some of the supplements. Turmeric probably has the strongest evidence to support its use, and short-term use of NSAIDs topically or orally. Interestingly, we think of bracing and not really sure, but there's adequate and ample evidence to support the use of bracing to reduce symptoms. What they do is decrease pain, stiffness, and even medication usage, probably through proprioceptive feedback. On radiographs with a good brace, sometimes the KL grade will look improved. Physical function scores, especially in those with varus or valgus knee deformity. There's really excellent physical therapy for focal chondral injuries. You may review this outside of this talk, but the rehabilitation program's goal is, as always, to reduce pain, optimize function, correct biomechanical factors, and provide a lot of education about joint loading. There are different phases of rehabilitation, including the acute phase, which is just to reduce swelling, restore range of motion, strength, and neuromuscular control. And then our athletes are advanced through joint loading, progressive functional activities, and if possible, return through sports-specific training. And certainly if at any point we're not progressing, folks, we need to really consider surgical collaboration. And lastly, but not least, our injection for chondral defects. Unfortunately, a lot of the literature is really more on early osteoarthritis than it is focal chondral defects, but we do borrow from that. Certainly corticosteroids have a role for short-term release of inflammation and pain, as does HA with probably about a 6-month window. Orthobiologics come in different varieties for injection, starting with prolotherapy, which is dextrose-based, and on up through birth products. Prolotherapy, there are really no studies on focal chondral defects, but there are at least 4 randomized controlled trials on its use in mild to moderate osteoarthritis with clear benefit at the 1-year mark compared with control groups. Platelet-rich plasma in NEOA, as you know, probably has the strongest evidence to support it in any joint. And there are multiple randomized controlled trials and level 1 evidence to support its use. Unfortunately, most of the data we have has to be by inference because the majority of studies looking at the use of injected PRP relate to OA of the knee and not specifically chondral injuries. As it relates to signaling cells, the evidence as of this year, there's good case reports and case series for bone marrow aspirate, fat, and SVF. However, the evidence, again, for regeneration is lacking. There's some limited evidence for culture expanded cells. However, we're not allowed to do that in the United States. And here's a nice review for further review. Amniotic products have probably some benefit. The only problem with them right now, as currently marketed, none to my knowledge is FDA approved for this indication and should not be marketed as stem cell therapies as they have no live cells containing within. So in summary, I think where we need to go in the future is to sort of predict response and use of non-operative techniques to understand more fully what the natural history of this is, and to see if we can come up with a consistent biologic marker that we can use to predict outcome and predict the role of our interventions. And that's why I'm happy to be part of the BA, as well as our own network for research that we hope to dovetail with the BA. So in 5 minutes, I hope I made the point that there's a role for non-operative treatment. Thank you very much.
Thanks, that was great. And I'll try to transfer over to the oxymoron title of conservative surgical treatment. And thanks for allowing me to help present this. My talk is burdened by the most data and literature of all the topics being given tonight. And if you stacked the literature of my talk flat as papers, it would be taller than all the other literature stacked end to end. So just keep that in mind as you're listening to the other talks. You know, when we think about the different options that are available, their standard surgical treatments, sometimes it gets confusing because when we look at general outcomes, it looks like all of them have generally high success rates. And we know now that if we look at this in a more detailed fashion, we can really understand that they all play different roles. My talk will cover very quickly debridement, microfracture, MACI, and osteochondral allograft plugs. I'm not getting into some other below the bar type technologies that don't have as much long-term clinical outcomes due to time. We need to think about these relative to some important factors that affect who we can give them to and how they function. So lesion characteristics, prior treatments, concomitant surgery, and insurance plays a big role of what we can actually utilize. We want to try to have this grid in our head so we know what to apply and when. I'm going to spend more time on debridement than you may think I would otherwise. It's an important part of this process of understanding what the defects look like, how big they are, how they compare to what we see on MRI, and also, most importantly, there's some symptomatic improvement that we can get from a debridement. So when we look at that part more specifically, we looked at a group of patients of Dr. Coles and myself who had ACI biopsy. Most of these were patellofemoral patients, and most of the patients that did not proceed with ACI transplantation or MACI, which is about 40 to 50% of patients, did not do it because they felt better after this treatment. We then did a prospective cohort looking at this for both tibiofemoral and patellofemoral patients, regardless of biopsy status. So anyone that was staged for cartilage treatment, and found that many more chose to move forward with transplants that had tibiofemoral involvement than patellofemoral involvement. And an interesting trend that we saw is that when we look at people who did not convert, they did not get better even at 2 or 6 weeks. But people, people that did convert did not get better. People that did not convert and said they did well and didn't want to transplant got better within the first 2 to 6 weeks after surgery. So we should keep that in mind in the conversation with patients and use it for diagnostic and therapeutic benefit. Microfracture obviously has probably the longest track record along with debridement. And the problem is that these outcomes really decrease over time and they're not really beneficial for large defects. There's different cutoffs anywhere from 2 to 4 centimeters squared. And there's a question as to whether or not these will burn bridges to future treatment. So we know that the outcomes in the patellofemoral joint are not quite as good as the tibiofemoral joint. And we also know that the long-term durability does go down, and Gudis's article is a great one to show that the durability symptomatically is not there. He also looked at failure rates and found a much higher conversion and reoperation rate there. MACI is one of the most well-established treatment options in this category and has probably the most literature along with osteochondral allografts. This does very well in both the patellofemoral and tibial-femoral joint. It has probably no upper size limit. There's a question as to whether or not you can use it after prior marrow stimulation, and osteotomy may improve outcomes. When we look at these populations, we know that it has long-term outcomes even beyond 4 years. There's 10-year data that shows that it's really well maintained at 80% or higher, and that we see that it actually has a good survivorship, potentially even after marrow stimulation. So there's three papers on this, and they're conflicting in that regard. It's also been shown that in the patellofemoral joint, the outcomes are better if you add an osteotomy, and so that works in synergy if you're using this option in that particular location. Finally, looking at osteochondral allografts, it's probably now that the patellofemoral and tibial-femoral treatments are equal. Size can really get as large as you want. The techniques are improving for that. And certainly you can use this even after prior treatments that have failed, such as cell-based or marrow stimulation. Generally very high success rate at 5, 10, and even 15-year data. Looking at survival curves of ACI versus OCA in the patellofemoral joint demonstrate they're fairly similar. We need similar information in the tibial-femoral joint, and that really doesn't readily exist. The survivorship of plugs are better than shells if we're using them in the patella, and we should consider that if we can with regards to technique. So when we start to take all this information together, we know that there's a lot to consider, more than I could certainly cover in 5 minutes, but we're burdened by the amount of evidence that we do have and some that we don't have. And we need to take into account some of the benefits of each of these techniques, as well as the downsides that do exist. And everything is a trade-off, but certainly there's many good options here. And most of the other options exist because people don't always have access to these options. Thank you very much, and thanks for allowing me to contribute.
Well, that's impressive, Adam. It's hardly ever the case that you're a minute short on time. It's probably because you didn't have such a large argument this time. So thank you very much for leaving me a minute, and I'll try to use it to the best of our attendance benefit. So my name is Daniel Saris, and we're trying to share with you the radical solution, which is always a little bit strange, because why do I always get stuck with a radical solution? It's not really fair. However, I'm okay with that, and I'm also not threatened by his suggestion that the literature on his solutions was what we would be living up to, because I think still that the literature that got MACI here is something that I gladly put my autograph under, so not to worry. Radical, I don't think I was given the radical solutions, I was given the logical solutions. And my reason for that would be similar to just basic life. We had the telephone and we had the telex machine for a very, very long time, and it worked perfectly well. But when the iPhone came up, everybody transitioned to that. It's a very simple one-stage solution, and nobody uses a phone and a telex machine anymore. These are my disclosures. So the basic thing for all of these cartilage repair procedures is going back to joint homeostasis. And you can come up with whatever solution you want, but it will not work if you don't consider the whole environment that it's being taken into. And that means that patient selection, interpretation of the data that Adam just showed you, and the regulatory aspects are really, really, really important. And as I always say, and I know that Adam and Ken and Seth know this, cells are smarter than surgeons. Cells are also smarter than scientists, and that's why we need to have the cells do the talking. And I thoroughly believe in the story that MSCs tell us. And that's why radical solutions are here. So at some point on a Friday afternoon, we came up with the idea of wanting to have patient-centered progress and being able to use one solution for base therapy of focal cartilage defects by recycling from the patient's joint, mixing it with allogeneic MSCs, which are smarter than surgeons, smarter than scientists, because they can listen to the environment, they can apply factors to the environment, then we improve the healing, they will improve the homeostasis of the joint. We're not afraid of a stack of papers, Adam. This is just something you need to go through. You send them to the FDA. They say, that's very well done. And they let you do the trial. And this is what gets stuff into the market. This is what patients need. And this is what our providers, all 137 of them listening tonight, are really waiting for. This is a scope that Dr. Reynolds, the resident that's online today, and I just did. This is a reclaimed case we did earlier today. A young colleague of ours, large femoral condyle defect, and you see the loose flaps. And the loose flaps hurt my heart as a sports medicine surgeon because the tissue is useless, but the cells are wonderful. So let's recycle them. Some industry partners say, well, you can't do that because they're large defects. Well, that's nonsense because large defects have larger rims. And you could do the pi r squared to the whatever degrees. Any defect you clean, the bigger it is, the more tissue you have left over. You add the allogeneic cells and you have enough to fix the defect. So the system that we came up with in the Netherlands and that we published recently in AGSM for, I guess it's the 5-year results, is pretty simple. You debride the defect. You can do that arthroscopically or open. You go in and clean the defect the way you're supposed to. We chop up the cells mechanically, we digest them chemically, and then we put them back into an environment where we mix them with 90% allogeneic MSCs or 80% allogeneic MSCs, depending on the dose, and we just spray paint them back in. We call it the bio-airbrush. It's a one-stage solution, and this will be the iPhone of cartilage repair, I'm sure, and I'm biased, but that doesn't mean I'm wrong. This is the example of the case we did. You just spray paint the glue back in. It's 12-minute resident surgery with all kinds of respect to everybody. It's the thinking and the science that matters. It's the 18-month paper that we did from Utrecht. And I'm totally biased because it's a 5-year outcome. It's not just a new idea. It has 5-year data already, which was published by my son. So it must be correct. The outcomes are similar to or better than the 5-year results that we see from Macy or that we saw from Chondral Select or that we saw from some of the other cell therapies before. And this is done within one surgery for 1/10 of the price, which is also something to reckon. And then just looking forward to probably next month's discussion, we'll also be thinking about osteochondral lesions. And that's where my friend and neighbor across the street here, Aaron Critch, came up with a radical solution, which is recycle pieces from osteochondral grafts in patients that are still alive. Living donor allografts, it's a radical idea, but it will work. We have the capability to do viability screening. We have the capability to make this be available in clinical practice. And I think that's where we're going. So where are we now? It's here to trial, and I'd be happy to treat your patients, and your patients will be happy for you sending them. In the Netherlands, we're working on the 10-year follow-up, and we're doing the RCT. Here in America, we're doing the validation of the European study using adipose-derived MSCs, just to show that it's possible on 2 continents. And then we're expanding the thinking, because it's just not a showcase, it's also science. And we want to apply this to the hip, we want to apply this to the meniscus, and then we want to transition this to the treatment of early osteoarthritis by understanding homeostasis and plugging into some of the stuff that Joanne was talking to us about. That's my argument. I don't think it's radical. I think it's game-changing. Thank you very much, team.
Anyway, so I'm Jack Farr. I'm in Indianapolis, Indiana, and I've been given the topic of, what's the party line? Well, you've heard the party line because this is the party. And I tell you, it's all over the place. I certainly have a bunch of conflicts.
And these are on the AOS website.
On this, so what's the party line? For me, I think just briefly, we like to promote innovation so I can appreciate what Dan is doing. We want to build up where we've been, and then we want to stay legal. So I think that's the 2 main things that we can all agree on. If you look at how we're going to promote innovation right now, where are we? You've already heard PRP for focal defects, probably, that's a long way off. There's conditioned plasma. There's other things you can look at, but I think that's right now still on hold. Peripheral blood derivatives. Dr. Saw in Kuala Lumpur initiated this. Then it's picked up by Adam Ans, who's in the US. He's currently doing an FDA supervised trial looking at the harvest of blood. These are peripheral mesenchymal stem cells, and then applying these to focal defects. At least Dr. Saw had excellent results. I hope they're corroborated. Bone marrow aspirate concentrate. You saw one review by Jorge. This is one that I participated in. We looked at systematic review, 10 animal studies, and we had 13 human studies. the animal studies were kind of equivocal. They had about 5 that said it probably works, 5 that says it probably doesn't work. And then the humans, they said, well, it looks promising, but if you really drill down and look at the level of evidence, most of these were pretty low on level of evidence. As far as adipose synovial-derived stem cells, Jason Dragoo as an RCT, looking at this, taking it from the knee fat pad, trying to reestablish focal defects. That looks promising at present. And finally, placental products, as far as an injection type of mode, I have not really seen a published paper for focal defects. Sam Tabbitt did one with actually sheets of amnion that did look good, at least in the sheet. So if you look at a summary of all these, if you look at the whole realm of stem cell treatments for knee articular defects as well as osteoarthritis, it shows promise, but really we have to look at the methodology, and we really need to up our game. We need to get these level of 1 evidence to make any really conclusions. As far as staying legal, I think you really need to be facile on understanding the difference between a 361 product and a 351. A 351 means that you actually need to take a license from the FDA. So they're going to require certainly a level 1 adequately powered trial. It's very onerous, very cost prohibitive for some companies. 361, that applies to most allografts. And unfortunately, we live right now in this gray zone of what is minimally manipulated, because of a 361 product of an allograft. If you mince it up, is that manipulated? Well, we're kind of dodging that by saying, nah, it's not really. But what if you add an enzyme? Well, you are manipulating it. You need to go through an FDA trial to get a biologic license. And certainly we're under the gun now. The FDA came out with guidance in 2017 that said, okay, we are going to get a lot more specific on these orthobiologics in terms of rating what is minimally manipulated, what is orthotopic use, what's homologous use, and especially with the many amnion and placental products, there's going to be some major shakeup. Really, we have to re-expose what are going on with minimally manipulative and what are the definitions, as the enforcement certainly will be tightened. So the FDA guidance, this was in 2017, it came out in November. It was originally that it was going to be early in 2021 because of COVID. It's been pushed back to the summer, but they're going to start zipping down the line, and they're going to be more and more specific on these minimally manipulated, stretching the truths. But even in that interim, you can see that if they see a product that may have the potential to significantly harm people, like injecting MSCs into an eye, they're gonna pull that clinic. So they're not taking time on these bad actors. But the rest of us, we really need to watch our P's and Q's as far as what is minimally manipulated, and are we staying on the right side of 351 and 361? Thank you very much.
Okay, everybody, thank you. Those were great quick talks, lots of big topics trying to be covered in 5 minutes. We appreciate your brevity. We're going to start some rapid fire questions to the group right now. We'll start with some questions on non-operative treatment. So first of all, I'd like to just put to the panel, patients comes in, they have early osteoarthritis and a sudden...
Oh, Ken, wait a minute. Who just popped on?
I can't see. I see a name, but who is this guy? We have somebody Zoom bombing us? He wasn't.
Lord.
David,
oh, wait.
Who gave you the keys to the door, David? This is David from Ohio State. We want to welcome him. Do you have something to add here?
Man, what a great conversation we're having tonight. I'm just so happy to be here with all my BA members and looking forward to the further discussion we have.
Okay.
What's your 2 cents, David? Come on.
That's it, huh? Okay.
What struck a chord? You heard 5 great talks.
What's so great about this topic is that we have so many challenges with, as I always say, road maintenance for our patients, right? So it's how do we maximize our patients in these difficult issues? And I think everyone's kind of outlined that very well. I struggle like most of us. How do we get them back towards a full active lifestyle? And as Andrea said, really making sure we kick that can down the road so that hopefully they can stay away from metal and plastic. I think where I'm going to be excited to hear what some of the conversation is, how do we use biologics with some of our surgery outside of what Dr. Saris has said as well, though? Those are my
we'll start with some simple questions then on non-operative treatment. I want to get a sense of the panel very quickly. If everybody can say or raise their hand, they'll give me an opinion as to somebody comes in with a focal defect, they have a fusion, or they have early osteoarthritis with a sudden exacerbation. Do you all still use cortisone as a first-line treatment for that patient when they're in your office?
Yes, very frequently.
If it's more osteoarthritis, yes. If it's not, then I'm going to try to convince them to use an orthobiologic, start off with PRP.
Dan, you gave a little wave of the hand. Tell us what you meant by that.
If they come in with an acute large effusion because they've clearly overdone it, but this is not their normal thing, then yes, I think doing a cortisone injection once is fine, but I don't want to fall into this trap of doing cortisone 4 or 5 times a year. I mean, I think that's fine. We have someone planned for an arthroplasty down the road, but young patients need more reconstruction than just palliation.
Dan, did you have a statement to make?
Yeah, well, statements, I'm not sure. So what I think is if patients have an effusion and they're young, it's the joint talking to us. And I think it's better to listen than to shoot it up with corticosteroids. So you need to find the cause of the effusion. If the cause of the effusion is mechanical or it's cartilage or it's meniscus or it's instability, then corticosteroids don't work. If it's something else or it's something we can't fix anymore, then corticosteroids are fine. But I think we need to listen to the joint first before we shoot it up.
Joanne, quick answer.
I would just say, I would agree. If it's something that you're trying to get to heal, sort of a new symptomatic defect or injury, try to let them work it through. If someone has some early OA and a sort of a life cycle event or need to be functional very quickly, we'll give them a one-time injection. I tell them otherwise it's cracked for their knee. They just want more and more, and it's not good.
Very good. And now another similar question. Patient has anybody using HA on early focal defects as a treatment along with anything else short of surgery?
Absolutely. I think HA and also PRP are common, especially for some of the patients who may not want to go towards a surgical solution quick, or especially if you're just trying to buy some time for life events. Lots of our patients have life events. They need to have a stopgap for 6 months until it's a better time for them for their work or for school. So absolutely, these are all part of the armamentarium.
You know, one step further, we've all talked about maintaining homeostasis. We want the best environment for whatever construct we are doing if we're doing an operative procedure. So I really would agree with that approach. I like to get the joint in a proper, the best joint I can have for them, because putting whatever tissue you are in a very angry, catabolic, inflammatory knee is probably not the best thing for your construct. So I will use it in that setting as well.
Yeah, I think we learned about alignment, we learned about meniscal preservation and ligament, but I think that the synovial milieu is just as important. So I think that's a worthwhile discussion. Adam, anything to add on that?
No, I completely agree. I think logistically, sometimes it can be difficult to do HA for focal defects without giving a diagnosis of arthritis, depending on insurance carriers. So sometimes that's a real world barrier. And then if you put an arthritis diagnosis in the chart to get that shot, and then you try to do a cartilage transplant, sometimes you have some tough discussions.
But I think injections like that can also help patients sort of come to terms with what they have, because I mean, frequently you see someone who has been diagnosed somewhere else with, oh, this is nothing really, you just gotta live with it, and then they come to us and get this diagnosis, and we have, cartilage transplant, meniscus transplant, like big surgery. There are many patients who are not ready to go from, oh, this will be fine, take an Advil, to all of a sudden have big surgery. And sometimes it helps to do a couple of cycles of injections. They see this is not going away, and then they come around and have surgery.
I want to ask another quick question on the non-operative. How many are using, patient comes in with bone contusion, subchondral edema, there may be some cartilage injury or not, the use of unloader braces to help these patients during the acute phase. Let's talk a little bit about that. I'm a big believer.
I can just add a couple of things.
Go ahead. Let's hear your opinion.
Yeah. absolutely want to unload that acute bone marrow edema and use bracing. That's different. There was another question about patellofemoral bracing, which I do not think is particularly helpful. It's different if you're trying to unload a compartment that's overloaded or you have an acute defect. The other issue is HA versus PRP that was in the question. Everything is regional. HA is rarely covered in Massachusetts other than Medicare patients and a few providers. Head-to-head comparisons always come out in favor of PRP, and HA is super expensive if it's not covered by insurance. So given the two options, HA is better if it's covered, but otherwise not.
Very good. Seth, you want to take on some surgical questions?
Sure. Actually, I want to ask Joanne one more question as our non-surgical representative here.
No pressure.
Can we project some data we know from OA injections onto the focal defect world for non-surgical treatments?
You know, I should be asking you that. I'm not sure, because I think these are different entities, at least clinically as a non-surgical person. And that person who wants to, what's their functional goal, and they really want to be active and they have a symptomatic defect, and there's a lot of bone marrow edema, and you pull out all your tricks and the joint is otherwise good, you know, I think they should probably be seeing one of you guys. I think otherwise, if it's a sort of focal injury on top of an otherwise arthritic joint, we can absolutely project. But there's such a mechanical component to these, and the joints don't respond to loading.
So, yeah. No, raise a hand. So of the surgeons now, so you have no mechanical symptoms, but you have a focal defect in a young person with normal x-rays. How many of you are treating that non-operatively and considering biologics? Raise your hands.
You said it's asymptomatic or symptomatic?
There's effusion, no mechanical symptoms. Are you treating that non-surgically?
I will typically do a single injection for a lot of the reasons we've already discussed, unless they have no meniscus or they have no ACL or other things that are pushing me to surgery anyhow.
Dan, are you operating on them?
Well, that's
X-raying the MRI, or are you treating the patient?
That's like taking your car to the car wash if it has a big dent in it. It makes no sense. So you need to do something about the structural problem. If there's a fusion there, it's not about putting an injection in, it's about something mechanical. Even though it doesn't click or it doesn't lock, the joint is talking to you, and we need to listen, and the solution is cell-based. And if you can do that with an injection, great. And if you can't, then the surgical solutions are very reliable.
So that's a very,
do you agree with that?
A very good old school approach. You know, I think that there's most of the things that cause pain in the joint are not related to the defect that we see. It's related to the synovium and the catabolic cascade that happens afterwards. Just like we know there's more people out there living with bone-on-bone arthritis with no pain than there are that are disabled by it. And I think if we can shut it down, unless we truly think that we can stop the progression of the arthritis within the joint or the progression of the size of the defect, it's not worth accepting the risks that come along with surgery.
Like a true surgeon. The only thing I would say is and I'm not overly aggressive, so I don't want anyone to get the impression that I operate on everything that moves, but in someone who lives with bone-on-bone arthritis, in a way, the decision has been made what the next surgical treatment will be, and that's a knee replacement. And for knee replacement, at least it's true that whether that happens tomorrow or in 5 or 10 years, by and large, there won't be any difference in outcomes. But for biologic interventions, we do have a window of opportunity. So at least we should have a discussion with the patient saying, for the time being, these are the things we could do. And can we palliate that with injections or PT or braces? We probably can for a while, but even if we get a 20-year-old patient to age 30, what do we do then? And if we've lost out on an option for biologic intervention, I think that I would not consider that a win. But yes, we do need to know more about the natural progression of cartilage defects and what a cartilage intervention does to change that.
And of course, what's changing now, what's really changing now is if there's really lower risk with things like Dan is talking about, or maybe these new aragonite plugs, things that may be less expensive and lower risk and have a chance to actually recreate joint surface. that's the thing that we haven't been able to do. We've had expensive options that can recreate temporary joint surface. If it's true that we can get better results and longer acting results at a lower price, then it may be that we'll be a little bit more aggressive. But I have always done what Adam did, which is, try to mitigate it biologically, mitigate it operatively.
So wait 1 second, Dan. Let me just preface this and then I'll go to you. So panel, everybody, Joanne, you're excused for the moment. Raise your hands if you routinely do single stage cartilage surgery other than debridement. Dan, are you raising your hand?
I was thinking about what you were really asking. So the answer is probably yes.
Okay, so you can explain that. Go ahead. And then I want to explain no, or maybe.
Like Dr. Farr said, like Jack said, we're sticking to the rules. So the reclaimed stuff is an IND, it's an FDA trial. So only very well selected patients go into the trial. And the other patients we treat with MACI or with an osteoarticular allograft. The allograft is a one-stage procedure, as even you know, Seth. The other ones are two-stage. So that's why I had to think a little bit.
Yeah, but that's a great yeah, go ahead, Jack.
They may be one stage in your mind, but in reality, for all my osteochondral allografts, I have to verify it to an insurance company. So that means I have to do a staging scope, establish where it is, what the status of the meniscus is, document all this. And it doesn't matter whether it's osteochondral allograft or MACI. I don't have your product, but when I have done trials, yeah, I'm just like you. If I'm doing a trial, the patients, you're not worried about cost. They don't care about how big the lesion is. I'll treat whatever I get in there. So it's a little different when you're doing a trial and when you're in the real world.
Well, I agree with that. I agree with that. And I also think that ties into something that Adam said in the beginning, which is really important. And that is the powerful effect of just doing an arthroscopy and a debridement. Sometimes that's the solution. But I also think that we overestimate the value of those data because of the hurdle that people have to take after we've done the arthroscopy with the biopsy for the cartilage culture and the debridement, and to get them onto something else. Sometimes they don't do anything else because it's too expensive or because their insurance doesn't allow us. And it's difficult to understand that insurance data and the scientific data and how to get the disparity understood there.
Dan Saris, I want to clarify one thing, and then I want Dave Flanagan to weigh in on this. So before you go, and that's important. You know the alignment, you know the BMI, you know the age, you know the activity level, expectations. You see the defect at the scope. You know if it's appropriate for single stage treatment. So you don't like microfracture and varus. You don't do things that are outside of the bell curve. You're in your clinical trial and you're staying within rational evidence-based medicine and trying to push us further. So that's applaudable and very important for those who are trying to do single stage. Dave, you have the floor, bud.
Yeah, Seth, I think from your first question is really just to go back with what Dr. Yanke said. We always don't know if the effusion is due to the cartilage defect. And I think as we approach these patients, it's almost like investigative, where we're trying to prove that defect is really the source of all the issues. And so I think, again, those conservative routes are very important. But you can't deny that a diagnostic arthroscopy with debridement and sizing that defect from a staging perspective can help some patients. It's been seen with Crawford's data, Yanke's data, and I think even with some of the old trials from Europe as well. So debridement can help, and I think it gives us a good lay of the land of the knee as to what's going to be the best treatment for that patient and make a best battle plan.
Excellent. Tim, you have any questions?
Can I ask a rhetorical question that's meant as a little curveball to stimulate discussion? So none of us want to be overly aggressive and operate on focal defects, at least not in the early phase. So that's the rhetorical question part. How many in the panel operate on ACL tears and rotator cuff tears? All right, but I mean, there's pretty good randomized controlled data from Scandinavia that shows that non-operative treatment is just as good for both ACL tears and cuff tears. So I mean, I operate on ACL tears and cuff tears. So are we doing wrong, or do we have a gut feeling that 2-year outcomes might not really show the whole picture? And that's a question to Adam. So you've showed that just a debridement helps with more than half of patients. I mean, we don't have the data yet. I'm looking forward to the data, but it's certainly something where if I see let's call it a 17-year-old with a large OCD lesion, I don't just do a debridement, even though they might be asymptomatic, because we have long-term data that shows that after 10, 20 years, they all get arthritis. So that data exists for OCD lesions. It doesn't really exist for focal defects. So should we maybe be more aggressive? I don't know. You tell me.
I think it's a balance of what other things that have been mentioned. So the more confident we become in surgical techniques, the more reliable their outcomes are, the more we know when to apply them and decrease risk associated with it. I think we start pushing the limits more and more. You know, the thing that is difficult is that most of the technologies we have available don't create normal hyaline cartilage. You know, they create something close enough that's usually good enough for hopefully long enough. And if we had something that put normal cartilage every time that was cheap and available, then I think we would start to push the limits, just like ACL techniques have gotten better. So it's pretty clear that if you leave an ACL alone, your risk of meniscus tears are higher. There's some associative logic. Then if you have meniscus tears, you get increased risk for arthritis. And so you put those together, and we don't leave young people alone. We don't even find out if they're going to become symptomatic after an ACL tear. So that's where it's common in the US, and I know it's not common elsewhere. So I think the pendulum, you know, is constantly moving, but I have not moved forward with, for instance, an osteochondral allograft and a medial femoral condyle. I will remove a fragment and wait to see and do maintenance x-rays over a year or two to see if they progress or not, as opposed to doing prophylactic treatment.
I think that's key, because I think that anybody under the age of 30, they're always my patient. I mean, it's not like, okay, 6 weeks and bye-bye. I want them back. I want to see them at 6 months, and probably if they're like 18 and they have a lesion, it's a focal lesion, I think it needs to be treated, but they're asymptomatic. I'm not going to treat it, but I am going to get an MRI at 1 year, and I'll even get an MRI at 2 years. I have several of these patients, and it's taken a while, but what I like to do is get to them before they have, you know, surrounding their shoulders are starting to get involved, or the contralateral side of the joint.
So Seth, we're running low on time, but I know you have a good question for Joanne.
I got a couple, yeah. One, a rapid fire, and then the word for Joanne. So how many of the surgeons use orthobiologic injections after cartilage repair surgery for focal defects? Raise your hands. So nobody uses PRP, HA, any injections whatsoever from time 0 to 2 years?
I do use HA. I thought you said other orthobiologics.
Oh, sorry. Any orthobiologic injections, PRP? I know we're, so Adam, go ahead.
Only if somebody's struggling. I don't do it routinely to maintain the environment, but I think it could be helpful for that reason. You know, we put these treatments in, they have a huge hemarthrosis. Hemarthroses we know are toxic to cartilage and chondrocytes. So I think that routine postoperative injections can play a role, and it's been looked at in animal studies, but I think we need to consider it. I
guess I should have framed it different, like boggy synovitis in the 2 to 5, 6 month range, trying to get homeostasis. Joanne, what do you think about that concept? Is there evidence for it? Should we study it? What should we be using if we did a cell-based repair like the gentleman described? They're still synthetic.
I'm not aware that there's any evidence specifically in what you're describing post procedure. I take my lead from you on that one, to be honest with you.
Dan had a statement to make on that question. Dan Saras?
No, I had a, my answer would be no, we don't use intra-articular injections. We do use anti-inflammatories, but I wanted to look at one of the questions online. One of the attendees had a question about the fact that we were talking about efficacy, and he or she wanted to know about safety. And the question was, are these therapies safe and are there risks? And I think that's important to address. So thanks for asking that question. So cell-based therapies are proven to be safe. And his specific question was, do osteoarticular allografts fragment? And is that an issue? And I think that's a question for Dr. Yanke.
Yeah, I think that one of the failure mechanisms can be subchondral cyst formation at the interface, and then you can get the bone to integrate, but the cartilage doesn't, then you can get delamination of that surface cartilage. And those rates have been variable in their literature, but sometimes reoperation rate for OA grafts are as high as 30%, but that's not always because of structural failure. It can be for continued pain. So I think that we're getting better with that, with potentially with bone marrow aspirate concentrate application before implantation, and that data is mixed. We're doing an RCT on that now. And then, I think technique and not impacting the cartilage, trying to do it press fit and keeping a tight seal so the synovial fluid doesn't get into that interface is helpful. But it's something that we think about for sure.
Joanne, can you give me, lastly, because it's all surgeons here and you, we're relying on you. Can you give us our 1 minute thing that we're going to take to our patients about all the other things that'll make our cartilage repair outcomes better? So you touched on nutrition, you touched on supplements, you touched on obviously weight, exercise, like just give us your spiel, like so that we can.
I literally, this is a 1 hour consultation with patients.
Well, we have, oh boy, really?
I know, so there you go. That's it. Send them on over. I'll get them ready for you. So the bottom line is that their body needs to be ready for this, whether it's a cartilage procedure, a joint replacement, if they're going to heal. We look at their vitamin D, their nutrition, their strength, their alignment, their balance, their control. And I tell them they've got to, especially if they're not ready right away, we got to get them ready for this, control the inflammation. And they're going to need to put the work into it up front to make it happen and be ready for you.
Excellent. Thanks. Well, Dave, any thoughts?
Seth, hey, I have a question.
Tell your patients about that.
Well, actually, I've got a question for all the rest of our great panel, and maybe Dr. Saris, you can start this. If you have a quiet joint, so not one that's a fused, but you're going to treat that cartilage defect, Dr. Farr kind of brought this up. What is everyone's thoughts on improving the environment? Is there a role for biologics before we even go in there with our surgical treatment? And can that, again, potentially help our outcomes? I think this is something I wrestle with, our team wrestles with, is, again, how can we potentially improve these patients even further down the road? So what are your thoughts, Dr. Saris?
Yeah, Dave, that is a super important point. And early on, and since we're still doing two-stage interventions mostly now, we thought of measuring the synovial fluid, measuring even urine components, and looking at the MRI scans of these patients and trying to use the interval between the biopsy and the treatment to pre-treat the joint. And we looked at factors like orthokine in the good old times and PRP, but maybe now MSCs to optimize the joint and prepare the joint for treatment, similar to making sure that an unhappy knee becomes a happy knee before you do an ACL. The problem is that we don't have measurement tools to understand joint homeostasis appropriately yet. And that's why I think that multi-center trials and large data with artificial intelligence and machine learning will help us to understand to improve the joint and pre-treat the joint for these biological interventions. So you're putting the finger on the right spot. We don't have the answer yet, and it's still a challenge.
One of our biggest things we have to look at is how do we determine who are responders and why they're responders for all of these biologics. And I think that that's something we're going to, like Dan says, that multi-center studies with large data are going to be essential. And we're starting to set up through the BA collaboratives to do just that. So we'll be excited to see this data in the future. We just don't have it yet. Excellent. So thanks a lot. That's going to take us out and close us out, I think, with a few last thoughts.
I think we could obviously talk all night, and the great part about this is that we learn so much in 1 hour from each other, and I think the multidisciplinary aspect of including our non-surgical colleagues is so important as we go forward. And so for the next, Vanessa, maybe advance the slides if you would. Very importantly, for those of you, almost 200 people who signed in today to see us, please go to the website. All these are available on the website. There's a ton of other vetted educational content, meaning that myself, Dave Flanagan, and others, colleagues have made sure that it's evidence-based that you can really rely on the data that's on our site. And it'll also go through clinical pearls techniques, practice management strategies, regulatory as the FDA comes out with new guidance. So please become a member and come on this journey with us. The second annual summit is at the front end of the combined AOSSM ANA meeting. I think the majority of those of us who are on this are now vaccinated, fortunately, and we're looking forward to convening together and really doing this in person. While Zoom has been so nice and effective for us to stay connected, I think that there's nothing better than being together and body language and really, being able to advance the field as one group in one place. And the next webinar for us will be biologic for tendinopathies. We're really broadening as we mature this webinar series. We're enlisting the help of all of our partners from all the non-surgical organizations. So I think that'll be a huge benefit. We're going to have other guest hosts. We're going to have surprise cameo guests. And so really exciting things forward for the Biologic Association and for Orthobiologics tonight. So to those of you who have drinks after a long and hard day, I salute you. I thank Ken to be our guest host. And please, Ken, lead us home with a couple of closing thoughts, my friend.
No, I think you've said it all. We're excited to be here and see each other. And we're looking forward to meeting in Nashville and hopefully going to the next level with all of our organizations at the VA. And I think that that's going to be the real future, is all of these societies speaking together with a single voice on this very exciting topic. So thanks everybody for joining us tonight. Thanks to all of our panelists. You've been great. And we hope to see you all again soon. And
excellent.
And in Nashville.
Everyone, thank you.
Thank you very much. Bye-bye.